And it is now my pleasure to turn this call over to Sana Akbarali. Sana, please go ahead.
Great, thank you so much, Urena, and welcome everyone. Hello, my name is Sana Akbarali, and I'm the Director of Family and Child Health here at the Association of State and Territorial Health Officials, or ASTHO. I'm excited to welcome you to our 6th virtual learning session for the Promoting Innovation in State and Territorial MCH Policymaking, or PRISM learning community. This learning community is co-organized with the Association of Maternal and Child Health Programs, or AMCHIP. Our current cohort is comprised of multi-agency teams in Washington State, New Mexico, Iowa, Arkansas, South Carolina, and the Commonwealth of the Northern Mariana Islands. We are thrilled to have the opportunity to hear from 3 presenters today who will offer their expertise on different aspects of adolescent mental health. Materials for today's webinar, such as speaker bios and handouts, can be accessed on Dropbox via the link that was shared in the chat just now. After we've heard from all 3 presenters, they'll have the opportunity to answer questions, so please feel free to use the chat or the Q&A function to submit questions. Next slide, please. The objectives for today's learning session are to recount the challenges COVID-19 has created for youth mental health, including educational, interpersonal, and health-related disruptions, examine one successful program and lessons learned to support youth released from a detention center through an enhanced medical home model that emphasizes mental health and well-being, and describe 2 strategies that state health officials can implement to support and advocate for youth and adolescents with mental health needs. Next slide, please. Before we turn it over to our speakers, we would like to note that the content, findings, and conclusions shared in this presentation are those of the speakers and do not necessarily reflect the official position of or endorsement by ASTHO, AMCHIP, or funder, the Health Resources and Services Administration. Please do not hesitate to reach out to any member of the ASTHO or AMCHIP teams if you have any questions about this disclaimer. It's now my pleasure to introduce our first speaker, Marissa Hauderschelt. Marissa is a member of Mental Health America's Collegiate Mental Health Innovation Council and a public policy student at University of California, Riverside. To read more about Marissa and today's other presenters, please refer to the speaker bio handout. Anytime during their presentation, please type your questions into the chat box, and we will answer questions at the end of all 3 presentations. Marissa, the floor is yours.
Thank you so much. Next slide, please. Okay, so today I will be presenting on college, COVID-19, and disability justice. And one little prompt I'd like to start my presentation with is, if you give a student a blank canvas with no paint or paintbrush, how will they paint the future? Next slide, please. Okay, so a little bit about me. My name is Marissa Hauderschelt. I am a 4th year undergraduate student at UC Riverside. I am a public policy major with a minor in education. I am queer, non-binary, and a first-generation college student. My preferred gender pronouns are they, them. I had the pleasure of serving on the 2019-2020 Collegiate Mental Health Innovation Council for Mental Health America. I have done some campus advocacy and some system-wide advocacy, which I will expand on in the next slide. Thank you. Okay, so first, the personal is political. Some questions I'd like to pose and answer. How can we be our own best ally? What does it mean to radically love yourself? And bipolar II disorder, what is it and how has it affected every aspect of my life? So, how can we be our own best ally? As mentioned before, I did put together a advocacy key terms sheet that will be available to you all in the Dropbox. So please refer to that if any of the terms that I mentioned in this presentation are unfamiliar to you. I want to make sure that everything is clear and coherent to y'all. And so starting with the first question, how can we be our own best ally? No one truly knows us like we know ourselves. Sometimes that's really hard because we feel like we don't know ourselves enough. However, through life, sometimes it just throws us upside down, and we have to completely refigure who we are and where we're going in life. This was the case for me. My second year of college, I was diagnosed with bipolar 2 disorder. It definitely affected my academic career, definitely my mental health, and also just every single aspect of my college experience. What does it mean to radically love yourself? I quoted in the advocacy key terms as embracing practices that keep us physically and mentally healthy, taking time to reflect on what matters to us, challenging ourselves to grow, and checking ourselves to ensure that what we're doing aligns with what matters to us. I felt like it was important to mention radically loving yourself because that was something that I had to do. Unfortunately, when I was diagnosed with bipolar 2 disorder, I did have to take a leave of absence. And within that time, I would say that I had to invest in radically loving myself. Next slide, please. Okay, so UC advocacy. So for the 2018-2019 school year, I was involved with the ASUCR Lobby Corps. My leave of absence was in the beginning of 2018 from winter quarter to spring quarter. So I was a part of this lobbying group when I returned back in fall. Thankfully, with my time off and my leave of absence, I was able to reconnect with myself on what I wanted with my future and what I wanted for the rest of my college experience. So I joined our student government lobby corps. It's an organization in our external office that teaches students how to lobby local, state, and federal officials around student-centered needs. The next question I'm asking is, what are student basic needs? Well, it's pretty self-explanatory. Student basic needs are food, housing, and basic health services like physical and mental health. Sorry, 1 moment. Going back to my experience at the ASUCR Lobby Corps, I joined because I began sharing my story. I felt when I came back, it was necessary to share my experience because I knew that I was not alone. I knew that there was other students that were struggling, especially first generation college students. And so within my involvement with this organization, it allowed me to advocate for myself, and it empowered me to use my voice and story to create transparency with stakeholders. And the last point, how can professors, staff, and administration further support college students? To put it frankly, believe students. There needs to be a shift in culture where documentation does not have to be required. There should be policies that protect students, and documentation should not have to be an end-all be-all when looking at disability accommodations. Next slide, please. So I had the pleasure of being on the Collegiate Mental Health Innovation Council for the year 2019-2020. So yeah, CMHIC stands for Collegiate Mental Health Innovation Council. Very long. So basically, the purpose of the council highlights the work that college folks do to fill in the gaps in services on campus. I was able to serve on this council with 5 other college students nationwide. We each had a research assignment, and my specific research assignment was on leave of absence policies in the University of California system. Basically, I wanted to know if my leave of absence experience was the same across the UC system, or if it differed. And unfortunately, my findings were that there was no similar leave of absence policy throughout the system. Every single campus had a different policy. A lot of them had fees associated with leaving. It definitely had to be planned out. And like when we're talking about an emergency leave, like a mental health break from college, we're not always gonna have the privilege of, scheduling a break. Sometimes it comes at you unexpectedly. So that was something that motivated me in researching this. I wanted to see if my experience, which I thought I felt really lucky in having a bunch of random occurrences that went in my favor to successfully take my leave. I wanted to see if that was the same on other campuses. And honestly, from what I saw, it put a financial burden on the student, and there's a lot of documentation required for it. So it was definitely a frustrating experience. And takeaways from the council and actions moving forward. We're looking to do an extensive policy brief. However, because of COVID-19, we definitely had to, I guess, reconsider our approach to our policy brief. So next slide, please. Oh, actually, before I go to the next slide, I do have to say a content warning / trigger warning of suicide and substance abuse. So please feel free to step away if need to. Oh, wait, yeah, okay, sorry, okay. So COVID-19 impacts. So on school. So the shelter-in-place orders began in March. It changed our approach to the annual Collegiate Mental Health Innovation Council report. We were going to do it on policies that would be student-centered on campus. However, because of COVID, we felt that we needed to do something that addressed the change to a virtual learning experience. So something that we came up with was the Fix Your Email Response campaign. I will talk about that at the end of this slide, but next I'm going to go to disability accommodations. In my experience, I do have disability accommodations on my campus, which gives me, more test taking time and a quiet test taking space. Unfortunately, when COVID hit and we had to go virtual, all of my accommodations were dropped with there was nothing that they provided in support. There was no emails, nothing. It was literally just classes were online, and it was at the discretion of the professors to honor them. And lastly, the impact on mental health. Going back to what I had said that I was going to say at the end, the Fixing Your Email Response campaign, our council wanted to empower students to hold professors, administrators, and staff accountable. We're looking to create a hashtag to let people express their experiences with switching to the virtual experience. And ultimately, it's to pressure the universities themselves to realize that they're not doing enough for their disabled students. And before I move on to the next slide, I would just like to reemphasize the trigger / content warning of suicide and substance abuse. Next slide, please. Okay. So here's a graphic from the CDC. As you can see, this report was put out on August 14th, 2020. And this survey was conducted at, it was June 24th to the 30th. And these were the results. Definitely very concerning. I'll take a moment just for everyone to take a look at it. Okay. So this was a representative panel survey conducted amongst adults 18 and up across the US from the 24th to the 30th. Overall, this survey had reported that 40.9% had adverse mental or behavioral health conditions since the start of quarantine. And the second point, suicide has increased among 18 to 24-year-olds at 25.5%. Specifically with minorities, with Latinx communities, 18.6%, and non-Latinx Black folks at 15.1%. And with essential workers, 21.7%. This was a survey of 5,000 adults, and it was web-based, administrated by Qualtrics. So, unfortunately, as you can see, this pandemic has had an adverse effect on all of our mental health. Being at home, for me personally, removed from my campus community has definitely adverse my mental health. A lot of us students find our college campuses as safe spaces and a place to escape. Being at home sometimes makes me feel stuck, and I know that I'm not alone. This is definitely a public health crisis. Next slide, please. So the urgency for disability justice, both for all students and for an equitable future. I'd like to ask everyone to stop and think about, what does it truly mean to have a fully funded and inclusive university experience? If you could please write it down or keep it in your mind for the panel discussion at the end. Another point I'd like to make is higher education and academia has failed in accessibility towards students with disabilities. For an equitable future, socioeconomic justice and racial justice is disability justice. When we begin to problematize and critique current social stigmas / norms from an intersectional lens, transformation is possible. All forms of oppression are intersecting. Ableism is often tied to classism, classism to racism, and so on. Disability justice has not been centered in mainstream conversations of social justice, especially Black, Indigenous, people of color, and other minorities. Next slide, please. So in conclusion, we must do better for all college students. Next slide, please. So this is just references and acknowledgements, definitely to the CDC, Mental Health America, where you can find free educational resources, and ProjectLet's.org, which is leading in radical disability justice. And lastly, I just want to say thank you. This is my contact information. Please feel free to reach out to me. And I hope you all enjoyed it. Thank you.
Great. Thank you so much, Marissa, for your powerful presentation and your perspective. And just as a reminder, we will be answering questions at the end of all three presentations. And with that, I would now like to introduce Dr. Andrew Shih for our second presentation. Dr. Shih is a professor in the Department of Family and Community Medicine and Pediatrics at the University of New Mexico and the principal investigator of the Focus and Adobe programs at the University of New Mexico Health Sciences Center. Welcome, Dr. Shih. The floor is yours.
Thank you very much, Sana. And thank you very much, Ms. Hauderschelt, for that very good presentation about the experiences people have in the university environment. I am speaking today about adolescent mental health and services that we've developed at the University of New Mexico for youth leaving incarceration. My contact information is on the bottom part of the slide. And if I may have the next slide, please. The Adobe Program, Averting Disparities and Outcomes by Building Engagement, is a program developed in Bernalillo County, New Mexico under the Behavioral Health Services Initiative, funded by the gross receipts tax passed by the residents of Bernalillo County in 2016. And part of the goal of the program is prevention of adverse childhood experiences or ameliorating the impacts of those experiences. In some sense, this window looking through an adobe wall into the landscape is somewhat symbolic of the way that we think about how we can construct our services. Could I have the next slide, please? By way of background, I had worked with a colleague in providing clinical services in the Juvenile Justice Division of the Children, Youth, and Families Department. And in the context of providing those services, we began to look at a cohort of individuals who had been committed to incarceration in the state youth prison in 2011. When we looked at pre-existing conditions for those youth, 100% of the youth had an Axis I psychiatric diagnosis, and 96.4% had a substance use disorder prior to commitment. Psychiatric services are provided in the facility, but there's no formal substance use disorder treatment, and at that time, no medication-assisted treatment. My colleague and I began to ask a question about what would happen to these male and female youth as they were released from incarceration, and what does a system of care look like for them? We could not at that time address the entire state, but in 2017, funding became available that we accessed to address the needs of juveniles, of youth leaving the county detention system. And we built a system of care based on information that we had developed from the state youth prison. Our first clinic in Adobe started in February of 2017. And then the next slide, I specifically want to address the mental health services that we built. So as one of the early critics of our plan said, youth who are being released from detention are going back to the same family systems where they may have encountered a lot of difficulty. And we definitely understood that and agreed. And so part of the Adobe program was to set up services for the youth leaving incarceration, as well as the family members who lived in their homes, who could affect the risk of reincarceration. So in our program, we built in psychiatric services and currently include a psychiatrist, a child psychiatrist, and a psychiatric nurse practitioner. Currently, from the time of release from detention to first appointment in clinic, there's about an 8-day span. And so this really reduced the time access issues for youth leaving incarceration in our community. Just to give you some sense of how many visits we've seen in the past fiscal year, we saw 200 psychiatric services in our 1.5 day of clinic with psychiatric services, and that included 46 new patient visits. As I mentioned, we see family members of youth released from incarceration, and most often that is a parent or parents of the referred youth. We also couple primary care medical visits with psychiatric medication management to assist with the psychiatric care. And so as a primary care physician, I work in conjunction with our psychiatric team to continue psychiatric medications under their guidance. We also provide substance use treatment in the form of medication-assisted treatment for opioid use disorder with buprenorphine preparations. And this is provided for the young person as well as family members who might have opioid use disorders. We have a combined psychiatric medical approach to methamphetamine, marijuana, and alcohol use disorders. And a big element of our work is to make sure that individuals with opioid use disorder have a current naloxone rescue kit prescription. The illustration is the website entry page for the Adobe program. Next slide, please. In addition to the medical and psychiatric services, we provide integrated wraparound services through individuals who we identify as navigators who meet with the young person in the detention facility prior to release and explain program services to each eligible young person who live in Bernalillo County. And then once they're released, facilitate appointments to primary medical and psychiatric services, and then make home visits to the home where the young person lives to get a better understanding of the legal, criminal justice, health, and social determinant needs for the entire family. In addition to addressing health harming social determinant and legal needs, we have education specialists and liaisons who interface with the schools where the young person might enroll. We found that most of the young people who have been incarcerated in our county have been out of school for up to a year and a half before incarceration. And so many of them are not currently enrolled in educational processes. The education support team provides connection to the schools and connection for the school personnel trying to plan out educational futures for the young people. These are critical supports for the mental health care of the young people we see, but that need for mental health is in some sense the next challenge for the program. The illustration gives you some outline of the work provided by the education liaisons and navigators and our partnership with the UNM Law Clinic that addresses civil legal needs for young people and their family members. The next slide, please. In the context of COVID-19, 75% of the psychiatric visits that are done have now moved to remote telephone visits for the most part. We are close to implementing video conferencing visits through a secure HIPAA-protected Zoom link. The psychiatric team feels that that will provide better assessment of the patient and better sense of how progress is going for the individual. 25% of our medical visits are being done remotely, primarily by telephone. Because of the state laws and requirements, navigation is being done completely by phone, which mainly means by text messaging, and educational supports were interrupted with the cessation of in-person school. But as school is beginning to start online in New Mexico, their work is becoming more complicated and more extensive. Major needs that we've identified, in part accentuated by the COVID-19 pandemic, as a need for behavioral health integrated with the Adobe program. Community access to behavioral health that was somewhat spotty before the pandemic has become quite inconsistent as individuals are having difficulty maintaining and keeping appointments. The other part is that there needs to be increased intention by behavioral health services and providers to coordinate with programs like Adobe to really complete the wraparound model. We have some future initiatives planned, one to address kids in school with behavioral and emotional challenges that exceed the capacity of schools to address them. These are a group of kids who, without intervention, and whose families without intervention might end up with kids expelled or suspended from school, or kids who become involved with the school police officer and then get sent to detention. Another initiative we've started is an agreement with the Second Judicial District Attorney's Office to address the needs of children in families where the DA's office has become involved on domestic violence. Their office and we feel that if we can organized services for children and families affected by domestic violence, we may be able to forestall some of the emotional and behavioral issues that would affect the child's education and social life. Next slide, please. So this is a brief overview of the Adobe program and its mental health and psychiatric services. And I very much appreciate the opportunity to present to this audience, and we'll look forward to questions and comments. Thank you very much.
Great, thank you so much, Dr. Shi. And last but not least, our third presenter today is Angela Kimball, the National Director of Advocacy and Public Policy at the National Alliance on Mental Illness. Angela, the floor is yours.
Thank you so much. I'm going to start by framing adolescent mental health in a public health context, followed by discussing a wide range of policy levers that impact youth, and finally follow up with some advocacy strategies. And with that, with the next slide, I'll start by stating that mental health and substance use disorders are really the chronic conditions of youth. Half of all lifetime mental health conditions appear by age 14, 3/4 by age 24. And NIMH research shows that the earlier you get treatment, the better the outcomes. The longer a condition goes untreated, the worse it gets and the harder to treat. So this is really kind of unique. Most chronic conditions occur when people are relatively older, later in life, yet mental health and substance use occurring early in life. Next slide, please. Mental health conditions are also surprisingly common, yet the rate of treatment is low and the cost to individuals, families, and communities is extremely high. Approximately 17% of youth have a mental health condition, but as Marissa pointed out, recent CDC data showed that at least among young adults ages 18 to 24, 74.9% of that age group, so 3 and 4, reported at least one mental health symptom, and 1 in 4 report having seriously considered suicide in the past 30 days. So even though we have these extraordinarily high rates, particularly post-COVID, the rate of treatment is low. Historically, only about 51% of youth have engaged in treatment in any given year. And yet, next slide, when we think about the ripple effects of that on the individual, on the family, in their community, in the world, it's really pretty profound. So Andrew touched on some of this by talking about the number of youth in juvenile justice systems, and we know nationally about 70% of youth in juvenile justice do have at least one mental health condition. And a little known fact is that after pregnancy and childbirth, mental disorders are the leading cause of hospitalization of teenagers. It's predominantly mood disorders like depression and bipolar disorder. I also want to mention that mental health conditions are the leading reason for people receiving federal disability. And then finally, suicide is the second leading cause of death for youth ages 15 to 24 years of age. So incredibly profound effects on people. Next slide. Yet we know with early and effective mental health services and supports, recovery is possible. And the point I would really like to hone in on is that disability and poor outcomes should be thought of as avoidable treatment and system failures. We simply don't need to accept disability and bad outcomes. And in fact, I referred to NIMH earlier. They did extensive study of first episode psychosis programs and found with early intervention with an array of services, they were able to help people with psychosis manage their condition, get back to school or work, and on with their lives, effectively changing the trajectory of something that historically has been considered a severe mental illness that people don't recover from. Yet it's entirely possible. Next slide. Ironically, adolescents, when people tend to develop mental health conditions and substance use conditions for the first time, there's a sharp drop-off in the use of primary care. As a result, I would posit that we need public health approaches. We need new policies to normalize mental health care and lower barriers of access for youth. Because while many youth stop going to pediatricians, they do, and certainly public health officials, healthcare workers often know this, they do go for reproductive health care, care for injuries. And when they can afford it, we hear anecdotally, seek out dental care. So this has implications for where to integrate mental health and substance use screening and services. Next slide. So now after this sort of public health framing, I want to shift to some policy levers and just explore a wide range in their impact on youth. And the first really is Medicaid expansion. So the importance of Medicaid expansion is unlike traditional Medicaid, which requires a young adult to go through a federal disability process successfully in order to access Medicaid coverage. Medicaid expansion allows young adults to get coverage if they are low income. So nobody has to say, I'm disabled. They simply have to have a low income. We're finding that that is dramatically increasing access to needed mental health and substance use services amongst young adults. Another policy lever that's kind of interesting, and it's not unique to young people, but it's definitely one to keep on your sites, 988 as a 3-digit mental health and suicidal crisis hotline. The FCC in mid-July actually unanimously approved the designation of 988 for this hotline. It will be operational in a couple of years, in July of 2022, which is fabulous because right now the suicide crisis hotline that we have nationally is 10 digits. Very hard to remember. 988, much easier. But to go with that, a number of mental health organizations are advocating for a range of crisis services. We're looking very specifically to the Crisis Now model of services, and that model has been supported by SAMHSA, the Substance Abuse and Mental Health Services Administration, as well as NASHBID, the National Association of State Mental Health Program Directors. And at its simplest, I would describe the Crisis Now model as including 24/7 crisis lines, non-law enforcement 24/7 mobile crisis response. Sometimes law enforcement is needed as a backup, but we want to minimize that involvement. And then finally, a range of crisis stabilization programs, including peer-informed programs. And this array, by the way, is present in Arizona, and at least in some areas of Arizona, definitely has reduced avoidable hospitalizations, reduced arrests, reduced law enforcement involvement, and help people get on the path of recovery. And in terms of Medicaid expansion, to hop back to that, I would mention that we are now, after ballot initiatives recently passed in Oklahoma and Missouri, those two states will become the 38th and 39th states to have Medicaid expansion. However, that still leaves 12 states, mainly in the South, Southeast, that don't have Medicaid expansion. Next slide, please. Now, some other kinds of policy levers are more in the public health arena, like public awareness campaigns. And you may be familiar with CDC's Know the Signs, Act Early campaign. It's designed to help people understand developmental milestones. And frankly, this campaign has been around for years, and I think it's been extraordinarily successful. Educators, parents, pediatricians, healthcare workers, a lot of people, even the general public, tend to know developmental milestones and really use those to gauge the need to get interventions or figure out whether or not there's any kind of delay or disability involved. Shortly before the COVID shutdown in early March, NAMI, my organization, actually met with the CDC because they're very interested in expanding this program to mental health. But they recognize that that would mean engaging youth because really the appearance of mental health conditions is typically in adolescents and young adults. versus babies and toddlers. Another kind of public awareness campaign is the Thrive New York City campaign. It's generated some criticism, but I'm going to point to a poster, which is pictured here, that says, "Anxiety does not define me. Today I thrive." And we think that one of the most powerful things you can do for someone who lives with mental health condition is to normalize it. This helps create a culture of recovery, not disability, and helps people engage in the care that they need. Another policy lever is definitely school-based and school-linked mental health care. And as Andrew pointed out, justice-linked or court-linked mental health care. And then I'll touch on one that comes from my home state of Oregon, although I now live in Virginia. Oregon passed a student mental health day. So it was student-led and really allows students to take mental health days off just like they would a normal sick day. And I think that gets to that whole notion of normalizing mental health, and really that sort of reverberated around the nation. Next slide, please. Now, after talking about all these policy levers, I want to mention 3 more before I talk about advocacy strategies. One is integration of mental health into primary care settings. Primary care is sort of a low threat way to get health care, and when mental health and substance use is integrated, it reduces the likelihood of people not showing up. Telehealth is another avenue for decreasing the barriers to care. What we're hearing from our allies at the Psychiatric Association and the American Psychological Association is that the expansion of telehealth during this COVID crisis has actually decreased no-show rates. So a lot more people are finding that they can keep appointments. For example, feeling physically ill, having a chronic condition that kept a person away from keeping an appointment, we've heard no longer is keeping people away from their appointments. It's low stigma, it's in one's own setting, etc. And the last policy lever I'll mention is the Family First Act, which really revolves around use of child welfare funds. And this allows states to apply to use existing federal child welfare funds more flexibly. So the funds that used to be used for placing a child in a foster care home can now be used in states that successfully apply to provide mental health and substance use services for parents, for guardians, for the youth or child themselves. So that's another avenue, policy lever, to get more money into a system to increase the availability of mental health care. And then lastly, next slide, I'll talk a little bit about some advocacy strategies. And I'll mention first that at the national level, NAMI brought together multiple leading mental health and substance use organizations and landed on 5 unified asks of Congress for the next, what we hope will be the next COVID stimulus package. We focused on emergency funding for behavioral health providers, extension of telehealth flexibility, the Medicaid Reentry Act, which would allow Medicaid coverage 30 days before release from jail, $3 billion for SAMHSA community mental health block grants, and a 7.8 percentage point FMAP increase. So I won't go into the details of those particular asks, only mentioning that because multiple organizations all went to Congress with the exact same message. We used social media, we used letters, we used media, op-eds, we used meetings with grass tops advocates, as well as with lobbyists on Capitol Hill. We really made an impact. And all of our asks were included in one or both bills, either the House HEROES Act or the Senate HEALS Act, which is pretty phenomenal, the amount of support we got. So to take those in abstract, I would say find points of shared interest amongst your allies or potential allies, and really think about what's the shared interest with hospitals, with health plans, schools, child welfare, foundations, racial and social justice organizations. The more people or organizations you can find that share an interest, and by the way, youth, young adults is often a very good starting point. That's a point where then one can make a unified ask. Basically, many groups carrying the same message. I would encourage everybody to use the power of media and social media. Even if you're an elected official, you can help engage in advocacy simply by sharing common data points that help support the message that advocates are sending. And I would end by saying, use the power of youth. Think of how powerful Marissa is. Think about Oregon's youth mental health-based success. There's real power there to leverage, and it's a phenomenal way to advance your message. And with that, I will end, and thank you for listening.
Great. Well, thank you so much, Angela, and thank you to all of our presenters for sharing your experiences regarding adolescent mental care, COVID-19, and advocating for change. We now want to transition into a panel discussion with our presenters. So I would encourage you to either type in questions into the chat or the Q&A box, or take yourself off mute if you feel comfortable doing so. But we did have a question come through our question answer box. And Angela, you talked a little bit about this and the use of telehealth, but given COVID-19, the use of telehealth is becoming significantly more popular. Do you envision the embracement of telehealth, telemedicine to treat individuals who may be using substances and or have mental health challenges or issues?
That's a great question, and absolutely. Actually, one of the things we're hearing is that the greatest increase in use of telehealth has been for mental health services. And it's actually occurring a lot with substance use services as well. In fact, the Congressional Support Act, which was pre-COVID, actually already started to pave the way for using telehealth for substance use. So I think this is actually the wave of the future. Even when COVID ends, I think a lot of people are finding that telehealth gives them enormous flexibility, privacy in many cases, sort of a lowered barrier to care. So I think it's a great question. I think definitely telehealth is making an impact on mental health and substance use services.
Excellent. Thank you so much, Angela. And Dr. Shi and Marissa, I would be interested to hear sort of your thoughts on telehealth and your specific work as well.
So for me, I personally use telehealth. I have behavioral health insurance, and that's definitely something that I use. So I think it's definitely something that is impactful.
We're very interested in expanding how this is done. One of the things we found, though, is that families and youth we take care of often have limited cell phone minutes or limited access to data or internet. And so one of the modifications that we're hoping to make is to have our navigators deliver safely devices that have those minutes or have internet connection, so that we can bring them into a model of service. Doing that remotely knocks down so many barriers in a rural state relative to distance, travel, gas money, having to set separate appointments for care outside of primary medical visits. However, the one danger is that for young people in a home, in maybe a more crowded home situation, having privacy and being able to discuss confidential information may be more difficult in that home context.
Great, thank you so much. Again, if you have any questions, please feel free to type them into the chat or ask them through the Q&A box, but we do have some questions on our end. And this is sort of a broad question. What do you see, each of you see as the biggest opportunities and challenges for adolescent mental health in a, I want to say post-COVID-19 world, but that might be wishful thinking. But as we move forward and as we think about, you know, what the pandemic looks like in the future, what do you see as the biggest opportunities and challenges, and how can we maybe leverage some of those opportunities and sustain them moving forward?
I'm not sure any of us have the answer to that. I think this is a strange new world. And I think unfortunately for youth and young adults, is such a pivotal time of life. And everything that we've known about in our normal expectations about how life goes when you're young have been flipped on its head. And I don't know that we can predict what the mental health and substance use after effects are going to be, and how we'll best be able to deal with them.
Yeah, great, thank you. And I think it's something that we'll all have to sort of navigate together. And I think the importance of stakeholder partnerships and recognizing that this is truly a multi-agency effort is really important. We did get a really great question in our chat around what are some suggestions on reducing the stigma of mental health for youth and adolescents?
I think it starts with a conversation. For me, I grew up in a Latinx household. Mental health is definitely dismissed. It's not existent. So for me, it started with a conversation within my household, and, you know, me having a bipolar 2 disorder, it definitely started, you know, becoming something that we talked about. And then from there, it spread throughout our family. So sometimes all it takes is that conversation.
I would echo that it's really about exposure in normalizing by talking about it. And it's not about dry statistics, it's about real lives. And I think we're seeing a lot more of that expressed in everything from TV shows to social influencers and celebrities talking about their own experience. And the more we can repeat those stories and share our own experiences, the more we break down barriers. And that was something, frankly, that wasn't common when I was a little girl. This was a topic that was not talked about. Today, thankfully, that's changing. There's still a long ways to go, but really, again, it's all about making it real and making it about people you know every day. They're working with you, they're yourself, they're your friends, your children, your parents. Really affects everybody.
And I really agree with the other speakers. The one thing in terms of multi-generational substance use disorder, however, are when you meet multiple members of the family who are using extensive amounts of marijuana or opioids, and then the young person's in front of us, sometimes what I find helpful is asking the young person, so what does that drug do for you? What is it that you're wanting to help? The young man, for example, today who is smoking marijuana 7-8 times a day for anxiety, that question allowed us to talk about pharmacologic treatment of anxiety on a short-term basis, just to see if that helped and could reduce his reliance on medical marijuana, partly on the economic issue that what we can prescribe could end up saving him money so that he can have a better plan for economic future.
Fantastic. Thank you so much, everyone. And before I close out, I want to give anyone else an opportunity to ask a question or take themselves off of mute.
Hi, Sana. This is Stacey Collins. Can you hear me?
Yes, we can, Stacey.
Hi, everyone. This is Stacey Collins from AmChip.
all the speaker presentations have just been excellent. Bravo to all of you. I do have a question for Angela, following up on your point about the Medicaid expansion and its power to improve adolescent mental health services. Is there any data or research from the Medicaid expansion early adopter states to show how the increased access to health insurance coverage through the expansion has made a difference in terms of the access to mental health services for this population?
That's an excellent question, and I wish I had a quick answer off the bat. Let's see. The federal government did some research that showed increased access to behavioral health care. I would say that some of the strongest research we saw actually came out of the state of Ohio, which showed a fairly high incidence of mental health and substance use needs in the expansion population, and a very high rate of engagement in some kind of services or treatment. And so I think what that is showing for people is that there's a need out there, there's an unmet need. And then I would say on a more anecdotal level, what we're hearing is from early psychosis programs that when young adults can get on Medicaid and get covered for care, they're able to sustain care after being in a program without the stigma and sort of, it's very hard on people to declare that they have a disability. Like who would want to say they're disabled? And Medicaid expansion allows people to get that coverage and access care without going down that road. So even from a personal individual level, incredibly empowering to be able to get coverage that doesn't require one to say you're disabled. And then at a more public health level, we're seeing data from states like Ohio that show that lots of people have a mental health condition or substance use condition that are part of that expansion population, and they have a high rate of accessing services.
And Stacey, I just want to say I would echo everything Angela said. In one of our programs where we were treating parents for opioid use disorder, we primarily started seeing mothers. And as a result of Medicaid expansion in New Mexico, what happened is that more and more fathers came in for opioid use disorder treatment who really hadn't accessed healthcare systems at all. So it gave us a chance to do comprehensive primary care, but also connect up with treatment for opioid use disorder and also evaluate for other underlying psychiatric conditions that we could begin to manage. And that's been incredible to see families stabilized, even if the parents aren't together, to see them both making progress around the needs of the young child, around their mental health, wellness, and their opioid treatment.
Fantastic. Well, thank you so much to all of our presenters for a fabulous discussion. If you have any questions remaining for the presenters, please feel free to send them to AMCHIP or ASTHO, and we will facilitate that connection to our speakers. We will also be sharing the slides, so you'll have that. And with that, we'll close out this webinar. For teams in the PRISM learning community, please remember that AMCHIP and ASTHO are here for your technical assistance requests. And we're here to answer any questions, brainstorm solutions, and connect you to resources and facilitate collaboration. Next slide, please. Lastly, please complete the evaluation for today's session. The link was just shared in the chat box for your convenience. Thank you in advance for your participation. Your feedback helps us to improve and create meaningful learning opportunities. And finally, again, thank you so much to our presenters and to our participants for joining us today. From AMCHIP and ASTHO, we wish you a great rest of your day. Thank you so much.